Assalamu alaikum, good evening. Welcome once again. I'm Dr. Asma Yasin. I'm a graduate of Al Khan University Hospital and currently working at Sindh Institute of Advanced Gastroenterology, SIAG. So I'm honored to be a part of this prestige conference. And today I'll be moderating this session 4 that is really very interesting, especially for the junior consultants and the people who are already doing residency, and especially we are looking at the faces of our seniors and the one who are the academic leaders here. So today's session is this session is about training in gastroenterology, challenges and opportunities in Pakistan. We are privileged to be joined by exceptional group of gastroenterologists with expertise in leadership, academic leaderships. So I would like to request our expert panel to join us on this stage. Professor Dr. Saad Khalid Niaz, Executive Director of State of Art Institute for Advanced Endoscopic Procedures, Karachi, Sindh Institute of Advanced Endoscopy and Gastroenterology, SIAG. Professor Dr. Ghayasun Nabi Tayyab, well renowned for his advanced endoscopic procedures, Dr. Zegam Abbas, consultant gastroenterologist and hepatologist, Ziauddin University Hospital, Professor Dr. Kashif Malik, head of gastroenterology, Sheikh Zayed Medical Complex, Lahore, Professor Dr. Sharbat Khan, head of gastroenterology, Bolan Medical University. He is actively involved and well known among the residents, especially in Balochistan. Professor Dr. Sher Rahman, Head of Department, Hayatabad Medical College, President PSG. Professor Dr. Mohammad Saleh, Consultant Gastroenterologist and interventional endoscopist with a special interest in transplant hepatology. He is working at Shifa International Hospital, Islamabad. So, you may proceed, sir. Dr. Tanveer Hussain, Head of the Department, Holy Family Hospital, Rawalpindi. Thank you so much, sir. Without further delay, we are starting our session. That is, I already told that we all are very interested to listen this session, and I hope the attendees will also join sooner. The hall will be filled at the end. So our first talk is Trainer's Perspective, the Impact of Revised Gastroenterology Fellowship Introduction Criterion by CPSP. I would like to invite Dr. Nadeem Hassan for this talk. He is the consultant gastroenterologist at King Faisal Specialist Hospital, Medina. He has extensive training and leadership experience across Pakistan and beyond, that is US. So please, I welcome Dr. Nadeem for his presentation.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizing committee, Kamran Bhai, Sher Rahman Bhai, and all the people who have participated to put this conference, international level conference, at this stage. I'm currently working as a consultant gastroenterologist at King Faisal Specialist Hospital, Medina Munawwara. So the question may arise in your mind that, how come I'm presenting upon this topic of the trainer's perspective on the change of the induction criteria by the CPSP. So just to give a little background, I was working at National Institute of Liver Gastrointestinal Disease in Karachi at the Dow University of Health Sciences from 2018, 19 and 20. Then 21, Allah subhanahu wa ta'ala took me to Medina Munawwara. So during that time, 2019, January, we started the fellowship training program at Dow University of Health Sciences. Dr. Hafizul Sheikh was the first trainer who was approved by the CPSP, and we started inducting candidates. First batch, we inducted 3 candidates. Secondly, I was also the trainer at Dow University of Health Sciences, Nilgit. And so I wanted to share my experience. In 2019 also, I enrolled in the Masters of Health Professional Education program at Dow University of Health Sciences. So as a part of my project, I had to do a research project. So this was my research project that I basically compiled, and then I'm presenting today. So Medina Munawwara, the best place to be on the face of earth, close to the eternal resting place of Prophet Muhammad sallallahu alaihi wasallam. This is where I'm working. And this is the title of my project, Impact of the Revised Induction Criteria by College of Physician Surgeons in Pakistan on the Adult Gastroenterology Postgraduate Training Program, Trainer's Perspective. Now, I had the option of taking the perspective of the trainer, taking the perspective of the trainees, or to take the perspective of the governing and the examining body, accrediting body, the CPSP. So I opted to take the trainer's perspective because it gives a wide compass, wide areas where the trainers who are directly involved in the training the trainees, they could give their perspective what has actually have transpired after the CPSP has changed is the induction criteria. So so this is the little background of the gastroenterology fellowship program, how it has evolved in the number of years. So as the information that I've collected and has been provided to me, CPSP introduced the gastroenterology fellowship in 1997. And that was the second fellowship after people who have graduated, from the internal medicine training and they have acquired CPSP certification examination. They were eligible to apply for this second fellowship in gastroenterology. And if I'm not mistaken, Dr. Zaglam Abbas was one of the candidates who had joined that batch of the first batch in 1997. In 2007, CPSP introduced another track in which they enrolled candidates in the intermediate medicine module, and that was for a duration of 2 years. And subsequently, these candidates were not required to pass any examination prior to their being induction into the gastroenterology fellowship itself. So they are true tracks. So one FCPS passed medicine, so they are required to pass internal medicine examination, have their FCPS certification. This intermediate module, candidates were only required to do 2 years of training, and even passing the exam, without passing the exam, they would enroll into the gastroenterology fellowship. So there was a smooth transition from internal medicine to gastroenterology at that time. So later, in February of 2007, this is the letter that was issued by the College of Physicians and Surgeons in Pakistan, and it basically stated that the gastroenterology fellowship will be a second fellowship, and that the person have to be basically pass internal medicine certification examination after completion of training of 4 years, and that this will be applied from July of 2020. So just give a diagrammatic depiction of this. So 1997 GI training program was started as a second fellowship. This fellowship was for 3 years. In 2007, the intermediate module was introduced, which is the duration of 2 years. And then after, they were going into 3 years of GI fellowship, and this was the first fellowship. So they did not have any certification after completion of IM training. So January 2020 was the last batch for induction via the both tracks for first fellowship and second fellowship. February 2020, CPSP decision that only FCPS medicine into GI fellowship second fellowship. And so this is from July onward, July 2020. So as per notification, the FCPS passed, medicine passed candidates, they were eligible. But we have to keep in mind that, those candidates of the IMM who were inducted in January of 2020, so they had 2 years in which after completion, they could still be basically enrolled into the gastroenterology. So there was 2 years of overlap between the FCPS medicine and also the intermediate module. But from July 2022 onwards, only the candidates that have passed internal medicine certification, the FCPS medicine, that they were eligible to apply for the gastroenterology fellowship. Now, although I had left and went to Saudi Arabia, but my colleague is still working at Dow University of Health Sciences and other leading hospitals in Karachi. So they informed me that the number of candidates that are being enrolled is declining, and to certain programs, they did not have even one candidate, being accepted in the gastroenterology fellowship. So that was a very hot topic, and I said, I'll take this as my research project and see what is the impact of this reduction of this new induction criteria by the CPSP. So that was the motivation for me to basically do this research project. So the objective of this study was to determine an in-depth understanding of the impact of recent change by the CPSP in the induction criteria of adult GI training program in Pakistan. So the method that was used, I used a purposive sampling technique. It was a cross-sectional qualitative study and semi-structured interviews of 10 trainers. Now the question that was asked when I submitted my project, also the thesis, from the BASR and the Dai University of Health Sciences, that why did I use 10 trainers? So as you all recall that the qualitative studies, when they're conducted, when they reach a point of saturation, meaning that all the candidates, they're not coming up with new answers. They're having a repetition of those answers. So at that point, the training, the further questioning can be stopped. We don't need to get more questions, more trainers or more people involved in the training. So we chose 10 trainers, and these were from 4 different hospitals, leading hospitals who were providing training in gastroenterology fellowship. In Sindh, I mentioned Sindh, but all of them were from Karachi. And they were all CPSP approved leading training centers. So 1 was from the public hospital and 3 from private sectors. So there were a total of 10 trainers that I interviewed. 9 of them I interviewed in person, and 1 of them was by the telephone while I was in Saudi Arabia. And their data was basically transcribed verbatim. So whatever they stated, we put that in the study, that this is what their statements are of the individual trainer. And we made sure that the confidentiality and the anonymity was maintained for all these trainers. So this was analyzed and by myself and also by the NVivo software. So this is just an interview guide. These were the questions that I posed to the trainers. So number 1 question was that with this change, do you see or foresee any demographic shift, male versus female, urban versus rural? The socioeconomic burden upon the inducted fellows. Now they have to basically be training for a longer duration of time. So definitely that comes with the socioeconomic burden. Then would they be willing to join the GI fellowship with this longer duration? Opinion regarding the appropriate duration of the training as well. 3 versus 4 versus 2, and the training period for the 3 years for gastroenterology. And then one of the burning questions was how many trainees have been inducted after the change in the structure of the program. So there's a witness of decline, or is it an increase in the number of trainees inducted in the training program? So to answer this question, 6 cycles of induction have occurred since this induction process has been in place. And to my knowledge, in those 4 centers, 0 candidates are continuing in the fellowship program, in the gastroenterology fellowship program. At 2 centers, fellows had joined, 1 in each center, but after a couple of months, they dropped out, they did not continue. So this is the idea. And one of the things that I came to know is that, this, although is a study from Sindh, but in Karachi predominantly, but this is the impact that they're seeing all over Pakistan. It's not only limited to Sindh. So another question was impact upon the training of the fellows. Are the trainers, training is going to be affected, is it going to be better, going to be worse, once you train those FCPS trained certified fellows? The quality of the trainees inducted before and after the change, do you see any change in the maturity? And this question, do you foresee that the trainees after completion of training would opt for GI other programs, or they will go for a subspecialty training? So these were different questions. And what the CPSP, did they engage the trainers to get the feedback from them? And finally, the remedial measures, if they have any suggestions. So this was the interview guide, the question that I posed to the trainers. As I mentioned earlier, the anonymity and confidentiality was maintained. So the trainers were basically assigned a code, and only the researcher knew about the actual names of these people who the trainers were. So now we come to the results. So thematic analysis was done, and there were 6 main themes that were generated out of this study, and the 11 sub-themes. So demographic and socioeconomic impact was theme number 1, trainee commitment and quality theme 2, program structure, impact on patient care. This is very important, the impact on the patient, how this training change in the training program has impacted the patient care. So this we'll discuss in the results as well. CPSP policies that feedback and alternative training and super specialty training pathways. So what I mean by alternative training, would the candidates, seeing that they have to go for a longer duration of training, would they go for some other subspecialty training in CPSP programs, or would they opt for, if they want to continue gastroenterology fellowship training, would they opt for, like, for example, MD gastroenterology program? So this was one of the questions, and this was one of the themes. Now, mind you, one thing what had happened during this change in induction criteria was that initially the CPSP told the trainers that this is also when the trainers gave me this feedback. They told the trainers that this change in the induction criteria would be applied across the border for all the subspecialties. And the rationale for that was that the CPSP felt that the 2 years of training in IMM training was not sufficient for the people who are enrolling in the subspecialty training program. So initially, they were told, the trainers were told that this will be applied for all specialty. But when actually the letter was notified, the letter of notification came, it only mentioned about the adult gastroenterology fellowship program. It did not affect pulmonary, nephrology, cardiology. So in these subspecialties, the people continued to do interim IMM 2 years training, and then they were enrolling into the subspecialty training program. So the question was, would they opt for other subspecialty training approved by CPSP, or would they opt for, if they want to continue MD, they may opt for MD gastroenterology training program. So these are some of the comments and some of the answers that was given by the trainers. So I've basically listed the T10 was the trainer number 10 that I interviewed. And what this trainer mentioned is that there's already a shift in the gender towards the female, because obviously there's greater number of the medical students, female medical students in the medical schools. Obviously they are going to progress and going to the fellowship training programs as well. So they do not expect, here the percentage do not expect gender shift. Trainer number 8 mentioned very few female candidates will be expected to join this lengthy duration of the fellowship training. If anybody will apply, it will be only male. Trainer number 9 mentioned that no one is ready to join, neither from urban nor from the rural areas. So this was the answers that I have mentioned from the different trainers. This is just an example. Theme number 2 was the trainee commitment and the quality of the trainees. So the trainer number 4 felt that they expect them to be more competent, more better, holistic view of the treating patients, expect to have more recognition in the profession, expect to have better psychomotor skills and manual dexterity. This is the CPSP certified doctors, and this is the opinion of this trainer. The trainer number 5 mentioned that clinically they are better, they are consultant level, it will be easy to train them from a clinical standpoint. They have to step down from consultant level. Obviously they have to grade down from the consultant level to a fellow. So level of trainees for 3 years of GI fellowship, it will be easy to train them for clinical standpoint, but they will have their own opinion. They have to be remolded, which will be a difficult task. The candidates with FCPS in internal medicine are expected to be less committed. And the reason again is because they already have one certificate from his CPSP, whereas the IM candidates that do not have any certificates, so they are expected to be more committed and more enthusiasm. So the program structure, the trainers felt that the 3 years of training in medicine is sufficient, and 3 years of gastroenterology, an additional 1 year if they want to have super specialty training, IBD, transplant, interventional endoscopies. And the other interesting thing, as has been pointed out as a consensus, this change in the training prerequisite for the subspecialty training should be uniform across the border. It should not be selective for gastroenterology, because what is happening is that people are opting to go into other subspecialty. For example, in cardiology, pulmonology, and nephrology. If it's 2 years IM, then they can go into their subspecialty of the choices. They cannot go into gastroenterology because the more number of years are required. And the number of training period, 3 years of GI fellowship, and then total of 6 years was mentioned as the total duration of the training for internal medicine and gastroenterology. Patient care. So this is the train number 10 saying a lot has been changed. Patients are being taken care of by medical officers. They do not have insight regarding pathophysiology and management of GI diseases, and so they call the consultant for trivial things. Thus, they are behaving like telephone operators. We are facing this situation for the past 2 years. They cannot manage even simple things for patients with GI diseases. They are not interested in learning. Patient care and safety of the patient are being compromised a lot. Impact of the patient management is due to lack of residents, due to non-available GI residents. The management of the patient is compromised as there is a lack of residents in clinic, night coverage, and endoscopic procedures. More patient burden per physician, because one of the things is if this thing continues, then down the road we will see lesser number of certified gastroenterologists. As a consequence, the workload on the gastroenterologist is going to increase. Looking at the population of Pakistan, almost 247 plus million, and the number of gastroenterologists, which I cannot find the number on a public website, how many actually are gastroenterologists in Pakistan. So definitely then the workload on the gastroenterologist is going to increase down the years. More patient burden per physician as less certified gastroenterology will be available due to reduction in induction of GI fellows, and thus will not be able to fulfill the need of the patient population of Pakistan having GI diseases. And then lower number of certified gastroenterologists and expected to have increased internists practicing gastroenterology, the pseudo gastroenterologists and doing endoscopic procedures. So this is one of the things that is foreseen, that now the internists after completion of 3 years, they will take some endoscopic courses, 6 months or whatever, 1 year, whatever, and then they will start practicing as a gastroenterologist. So this trainer was of the opinion that this number of the pseudo gastroenterologists doing endoscopy procedures is going to increase. So this is a question regarding the CPS policy and feedback. So one of the trainer mentioned that this was in like 2015, 2016. We were informed that the main reason for introducing the change was that with GI, the first fellowship, the candidates were weaker in internal medicine. So I supported the CPSP viewpoint. But when we saw the consequences of the change, we gave feedback to CPSP, but they are not willing to listen to us. So this is regarding the alternative training, and as mentioned, most likely the candidates are after passing MBBS, will be opting to joining programs having lesser number of years of duration training, like the MD program. And regarding it is expected more candidates will proceed towards a non-CPSP approved, non-accredited training in endoscopy and start practicing gastroenterologists. It is even being practiced present time. Physicians require few months of hands-on experience in endoscopy, and it is expected to have increased internists practicing gastroenterology, pseudo-gastroenterology, and doing endoscopy. So this was the response. And then the question was here, endoscopy training is in non-approved, non-accredited centers and by trainers has been going on for some time. Even the technicians are doing endoscopic procedures, but those numbers are very low, up to 1%. So these are some of the remarks, some of the statements that the trainers had given. And so the final results here, that there was a positive trend towards a better quality of inducted trainees, but at the expected cost of reduced numbers of overall certified gastroenterologists, and particularly the female gastroenterologists, the possible rise of substandard non-certified pseudo-gastroenterologists compromising patient care. So the result of this study was the internal medicine training for 3 years sufficient, and then basic gastroenterology for 3 years. The GI super specialty training centers are a dire need of the time. Accrediting body should periodically inspect and revalidate the training programs. Regulatory bodies should ensure abolishment of an illegal, unlawful practices by the physician. So the conclusion of this study was that this study extensively looked at the multi-dimensional ramification of the change in the induction criteria of the adult GI fellowship training and concluded the expected overall impact of the change of induction criteria is not favorable. The policymakers, being socially accountable, review and amend the induction criteria after mutual consultation with all stakeholders for the larger interest of the trainees, trainers, and the Pakistani population at large. So this was the conclusion, and there were some recommendations also, which I know I'm running out of time, but if you want, I can mention about the recommendations that came out. The optimization of the training, the smooth transition of the training from medicine to GI, proposed structure of GI, reevaluation, revalidation, and regulation of physician practice. This is the recommendations. And we already discussed this, should not exceed 3 years of internal medicine. Subspecialty should be applied across the border, that all subspecialties should have the same prerequisites for induction into the subspecialty training program. And now, one other thing that came out, that people can have option that they can opt for 3 years of internal medicine before going to subspecialty training, and they can be awarded MCPS in internal medicine. If they want to pursue career in internal medicine, they can complete 4 years and then be eligible FCPS in internal medicine. This has been practiced in other parts of the world, like Canada as well, where the people branch off with lesser training into subspecialty, and then if they want to continue internal medicine, they do more training. And the other thing was that the training, just like the IMM module going into subspecialty, the transition from internal medicine to gastroenterology or other subspecialty should be continuous and should not be interrupted, that it can go without an exam. Because according to one trainer, the source of apprehension and fear for that person. And then they can take the internal medicine exam while they are doing their GI fellowship, and they should not be eligible for GI board exam until they clear the internal medicine exit exam. So structure, we have discussed this structure the same, and then reevaluation, we have discussed this period reinspection, reevaluate, and should be a part of the international accrediting body. And they should abolish, regulatory body should abolish all legal, unsafe, unlawful practices. And because this is jeopardizing patient health and lives, safety of the patient. So the conclusion again was this study extensively looked at multidimensional ramification, the change in the induction criteria, GI fellowship, and concluded that expected overall impact of the change of induction criteria is not favorable, with only minor benefit of quality of inductees. The policymakers, being socially accountable, review and amend the induction criteria after mutual consultation with stakeholders for larger interests of the trainees, trainers, and the Pakistan population at large. With that, I thank you so much for that.
Thank you, Nadeem. We'll take all the questions at the end of the session. So thank you very much. I think we should move to the next presentation.
Thank you so much, Dr. Nadeem Hassan, for sharing such a valuable evidence-based talk, and it has much generated a sparkable discussion. So our next talk is overview of postgraduate training in Pakistan, and it was planned to be delivered by General Dr. Farooq Saeed. However, due to some unavoidable conditions, he is not able to deliver. This talk has been merged with Dr. Amna Subhan's talk, so that is training in gastroenterology. So that is advanced endoscopy training in Pakistan, challenges and opportunities, by Dr. Amna Subhan. She is Associate Professor and Program Director of Gastroenterology Training at Al Khan University Hospital. Dr. Amna Subhan, please.
Right. Thank you very much, Asma. So, all right. So I always believe early in the morning or late hours, the audience staying in the hall is always very motivated. So thank you very much for being over here. Good evening. Good evening. Good evening. Thank you. Walaikum assalam. Bukhair Raghli once again. All right. Okay, so as Asma mentioned that the first few slides, I've made it very crisp, and I've shortened my own presentation just to merge two presentations. So initial slides of Dr. Farooq Saeed, and I'm presenting on his behalf. So Dr. Farooq Saeed's presentation is actually focused on, mainly when I've gone through the content, it's mainly about, is a kind of, do we have enough strength or capacity of trained gastroenterologists in Pakistan to cater the population of Pakistan to treat GI and liver disease or not. So that's the main focus of his presentation. So it has been estimated that the required number of gastroenterologists in any country, WGO recommends in 1 in 200,000, AGA 1 into 50,000, ESGE 1 into 30,000. So this is a kind of a calculation international bodies have recommended. So with the population of Pakistan approximately 250 million, WGO standards, we require 2,500 gastroenterologists, AGA standards 5,000, ESGE 8,000. So what is the situation and availability of trained manpower as gastroenterologists in Pakistan? So the total number of fellows has been graduated so far is 692 under the umbrella of CPSP. This number doesn't include MD as well as other training programs if there are any, but this is basically the CPSP graduates. So now how about the number of the people who are actually under training? Approximately 50 training center, 90 supervisors, trainees still in the pipeline is approximately 204. And this is the distribution of armed forces, private sector and the public sector driven training center. And these are the 204 trainees who are still under training. And you can see the distribution of institute according to the province and the supervisors and the number of trainees and the distributions of gender for male as well as the female supervisor. And the trainees approximately 68.6% male and 31.37% female. So this is the distribution of all of these CPSP enrolled trainees. So other than that, it might not be a very accurate data, but this is a kind of data collected in an informal way. So the trained gastroenterologists who have been trained outside of Pakistan include 200, MD gastroenterology approximately 100, residents completing the training and appearing in exam 200, it's 204 in the previous slide mentioned, which makes the strength of total number of gastroenterologists in Pakistan right now is like 1,532. And as a note, what have been communicated that this is a kind of a rough estimate, not an accurate one, as we haven't included MD gastroenterology in this number, and the accurate number of other people who have been trained outside of Pakistan is not that accurate, might be a little more than that. So the one major problem that Dr. Farooq thinks has been identified is asymmetric distribution, because most of these trained physicians or gastroenterologists, these are actually centered and practicing in provincial capitals. Public sector employment, private sector employment has been always challenging. Distant cities, remote areas, they're deprived of these people, and there is a preference towards from the graduates that the most of them is actually concentrated in the main cities, mainly the capital cities where they're practicing, where if you calculate the proportion, this is bigger as compared to the smaller cities. So we all know that there is a high burden of GI and liver diseases in Pakistan, and among the GI diseases, functional GI disorders, IBDs, MASH or NAFLD, liver diseases, CRCs, all of these are actually among the top diseases in the domain of GI and liver disease, which required to be well taken care of by the trained source. So all of these graduates are actually, by the end of their training, they are supposed to be qualified enough to treat all of these diseases. So burden of liver disease, you know well, C, B, other causes of liver diseases, MASH is a prevalent problem, HCC is a high burden in Pakistan, and again among luminal GI, if you consider the neoplastic diseases, colorectal, pancreatic, gastric, and esophageal cancers, these are actually type on the list. So based upon that observations, it has been concluded that the availability of gastroenterologists in Pakistan is not insufficient. If it's not sufficient, but it's not very insufficient. The quality of the service is extremely important, because definitely completing the number of years and exiting exam in 2 phases written and then 1-day clinical exam may not be able to translate them into a really good, competent gastroenterologist graduated from every center. So the quality of the training across different centers varies, and hence the quality of every single graduate who will be delivering the care to the patient will vary. So the number of the positions in the public sector hospital required to be enhanced so that this trained task force can get and employed after the graduation and will have a good future. Services at the level of the DHQ should be enhanced and incentivized so that they prefer to stay in the smaller cities, their hometowns, and they can deliver the care to their near ones as well and their own city as well, rather than looking for the better incentive in the capitals. And again, the same problem exists, the shortage of jobs for the gastroenterologists, trained gastroenterologists in the major cities, while there are so many people are actually available to deliver the care, and again the smaller cities are deprived. And here Dr. Farooq also think that a survey for the level of the care in the different areas of the country should be carried out. This will actually help us for the need assessment for the trained task force across the Pakistan. So from here, then I now move to my own topic, which is advanced endoscopy training in Pakistan, challenges and opportunities. Quite a bit is a continuation of the same topic. So when I started looking for, I didn't find any data. Definitely we discuss these things a lot whenever we meet with each other. Again, a couple of people are actually in the CPSP, Faculty of Gastroenterology. So this is something many of us has been talking about for years and years. But what about, somebody has looked into up? I thought that rather than touching on international data, ye hona chahiye, I felt better, okay, let me reach out to my own people and let's see what their perspective is. So this is kind of an ongoing survey. I'm sharing the initial few results. Advanced endoscopy training in Pakistan, gaps, challenges and opportunities. So what my own people think about it. So far, very small number of participants has responded. Thank you very much to all of them. 78% male consultant. All of them are practicing gastroenterologists and they're working in the different center. So the question that has been asked to them, most of them are actually working in academic center. For example, 50%, few were government academic center, followed by academic university-based center, and other than that, government hospital, private hospital, non-academic and none. So far from the different cities, you can see that few people responded from Larkana, Multan, Quetta, Mardan, Karachi, and all in all. So most of them has actually had 57%, more than half of them has actually had an experience of more than 19%, and 85.7% of them is actually they perform advanced endoscopic procedures in routine in their clinical practice. So how many years of training they have actually attained in advanced endoscopy field? Most of them were actually doing ERCPs. 21.4% were doing EUS, EST, EMR, one faculty member, capsule 3, manometry 2. Definitely this is not a very reflective data for Pakistan, but definitely this is just a beginning. Maybe next year the data will be in a better position and I'll be presenting that. So where did you receive your formal training if there are no structured program existing over here? So majority of them is actually have been trained in Pakistan through an experiential learning way, which means you've completed the training, you're working in a center, you get attachment with your professor, now you're doing procedure under his supervision, and then you have been like trained in a kind of an experiential learning model. What was the duration? And you can see that this is 6 months to 1 year for 21.4% of the participant, less than 6 months, and more than 1 year, 35.7%. Almost 1/3 is actually had more than 1 year of training. Was it an observational or you really get it hands-on or both? So majority had hands-on, both hands-on and observation, 35.7%. Have you considered pursuing advanced endoscopy training abroad due to the training available at the local center? You can see that 2/3 said yes. Have you encountered difficulty in securing formal supervised training for advanced endoscopy? 86% faced difficulty. Do you have access to simulator? 50% yes. Some form of simulator, not necessarily GI mentor kind of, but some kind of simulator. Do you think there are enough training programs available for advanced endoscopy training in Pakistan? Here you see the consensus. Everybody feels there is a need. Do you feel there is a lack of availability of trained faculty supervisors for advanced endoscopic training in Pakistan? So the perspective is 71.4% says yes. What are the main barriers for receiving advanced endoscopy training in Pakistan? And multiple people responded. So you can see that majority think that there is a lack of training center, limited availability of trained faculty, limited availability of training program, and you can see that the major number is actually again coming for limited availability of training center where the structured training could be delivered in this capacity. High cost of training, difficulty in securing international fellowships if you want to get this training abroad. So these are the challenges and the barrier in terms of training in Pakistan. How you would rate the quality of the training, whatever is available in Pakistan, in a form of experiential model? And I know now in 2025, there are few programs in country, they are actually providing a training, structured kind of training, but definitely there are few in number. But this is an overall perspective that how you rate the quality of the training. And here you can see that none graded it as an excellent. Almost 1/3 graded as good, almost 1/3 graded as fair, and then the same for the remaining one. So what type of advanced endoscopic procedures are available for training in your center, we asked them. So most of them is actually had ERCP, few had EUS. Luckily, few center has an availability of EMR expertise. Third is space, response 0, but we know that at least there are few centers who are doing it, including Dr. Ghaya's center. Manometry to capsule endoscopy and polypectomies, majority of them. Do you have a structured, standardized curriculum for advanced endoscopic training in your center? Why did we ask this question? The quality of the training this is a backbone of any training program. Structured curriculum and then delivery of this curriculum through right way of correct adoption of teaching learning method will make the program successful. So here you can see that 71.4% don't have any structured curriculum for advanced endoscopic training because they've been doing it through an experiential model. What are the main barriers for receiving advanced endoscopy training at your center? Again, more or less kind of same issues which has been highlighted before as well. Do you think CPSP should start training program in advanced endoscopy? Almost everyone says yes. So, so what should be the duration? What do you think that what should be the duration? 2 years, EUS, CRCP, EMR, ESD combined. Majority is actually rated for that. FCPS, advanced endoscopy, 2 years, EUS, ERCP, with that 35.5%. Certificate program in therapeutic, for example, ERCP, EUS, 1 year certificate program, 35%, 28% responded for that. The same kind of thing for the certificate programs is actually a little lower, but majority of the people think that combined advanced endoscopy program would be a better option for all of these things. I think talking to each other and again living, growing, practicing in my own country, whatever my perception was, the same perception is actually coming from the data. There is a dire need for the structured training program for advanced endoscopies Pakistan, but with a better quality, with a better accountability of the training program and the supervisor, so that this question of quality will never affect this advanced endoscopy program like the first GI fellowship program. So I think the crunch would be that it's needed, it should be done, but thoughtfully done, plan well, execute well, with a better accountability so that it would create competent graduates and this question of quality will never come. So this is a great thing that under the leadership of Professor Ghayasun Nabi Tayyab, CPSP Faculty of Gastroenterology is working on developing this this proposal of FCPS in Advanced Endoscopy Fellowship Program. The minimum duration of any fellowship program, the CPSP is actually proposed or approved is 2 years. A lot of work has been done. We are almost towards the final stages and to finalize this program. But this program will be based on, the proposal is actually based on structured curriculum, clear and robust criteria for the selection, for the for the supervisor approval, clear and robust criteria for the requirement for any center to get recognized, which simply means that they should have all facilities available whatever is required for that program, including equipment, enough volumes, training capacity calculation, so that there should not be any delta, bigger delta for the number of trainees and number of volumes or number of equipment, which is one of the major source of low quality of training in any center. Better infrastructure, other availability of other associated services, a structured plan for implementing strategies for the delivery of the curriculum, standardized process of application and selection process for fellows, continuous ongoing assessment during the fellowship and the end of the fellowship with feedbacks, periodic re-accreditation of training center, so that the centers will work really hard with efforts to maintain their quality, bring them closer to at least regional level, if not the international level. In summary, ladies and gentlemen, there is an immense need for implementation of a structured training program for advanced endoscopy training in Pakistan. Maintaining the quality of the training is even harder than just submitting and getting an approval of a program. And the robust strategies would require to be implemented right from the inception. Thank you very much for your kind listening. Again, you are invited for this conference. Thank you.
Thank you, Dr. Amna Subhan, for stimulating such an insightful discussion, I hope, at the end. So if anybody has questions, they may send their questions to WhatsApp on the number that I am announcing, that is 0329 5399 734. So I repeat, 0329 5399 734. Thank you. So our next talk is also quite interesting, that is training in gastroenterology, the role of clinical governance, by Dr. Rizwan Dayar Khan. He is consultant gastroenterology with endoscopy lead at North Manchester Hospital. Thank you.
Assalamu alaikum. I think one of my nightmare scenario was to be the last speaker on an exciting day with all those exciting talks. So I would like to especially thank Kamran and the team for inviting me, but I'm less thankful for the topic he chose for me. So if you are bored, now you know who to blame, and it's not me. So I am going to take a start, so I don't want to be taking too long from here on. So I've been to a couple of talks and I have no financial disclosure, and every time I will show this slide to be empty. I was a bit ashamed. So I thought there must be some association I should be able to share with my colleagues, which will define me, and then they will know who I am and the way I think about things. So yes, this handsome person in the front is me, which you can tell, but can anyone guess what is the mausoleum or the building in the background? Yeah, so it's Konya, and it's Maulana Rumi's mausoleum. And I think the importance of, showing this is twofold. We are talking about a training in gastroenterology. And I do feel that Maulana was a well-established personality within himself, be it followers, be it knowledge, be it status. But when Shams entered his life, it upended Maulana, and we ended up with Rumi, the Rumi which the whole world looks forward to, listens to, and admire. So I think all of us who are trainers, teachers, we are privileged to touch the life of our trainees. And I do hope that we are touching it in the right way, making positive impact in their life, changing it for good. Now, I think in today's talk, which is about clinical governance, so I will spend a few slides just to outline what I do mean by clinical governance within the setting of National Health Services England. And then I will show a few slides at how this process is incorporated within the training curriculum. So by clinical governance within NHS structure, what we do mean is that all the health organizations within the United Kingdom, they've got the responsibility that they are accountable for improving the quality of their services. And once you achieve any good standard, you have to maintain it. So you have to continuously show that you are striving to improve it. But if there is something which is working, then you have to keep on demonstrating year on that you are maintaining that standard. And the usual approach is we define it as the 7 pillars of clinical governance. I am aware that in different systems, different countries, there might be different ways of approaching this subject, because we all do know that safety is at the heart of everything we do. And I think patients are at the forefront of everything which we do. But in NHS, I think these are the different pillars, the different aspects which ensures that we are achieving what we are claimed to be achieving. And just to briefly touch on all of these in the context of gastroenterology services. So the first pillar will be clinical effectiveness. And I think when I've been listening to a few talks, I'm getting jealous. 2 weeks ago, I asked my pharmacist, I want to prescribe a PCAB to a patient. And he said, you can't. United Kingdom with more than 110 billion pounds health budget for 70 million patients, and I'm not allowed because it's still undergoing through a cost-effective study by NICE. And I think we all have our quarrels with NICE, but I think that just tells you that what a stringent criteria I am living my life in as a gastroenterologist in the United Kingdom. And then that applies to the BSG or some of the other guidelines. And if I do have guidelines, then I have to prove that I have got an IBD pathway when I am delivering that within the setting which I am working. So I work in North Manchester General Hospital. It is one of the most deprived areas by UK standards. And I think if I have to deliver what ECHO and BSG recommend, I have to come up with a pathway where I can show that I am doing what I'm supposed to do. So the same pathway might not apply, but I have to keep on showing it that I'm doing it in a cost-effective and a safe way. Risk management. Gastroenterologists used to be afraid of making holes. We are doing it for fun nowadays. We are going down through the layers from EMRs to ESDs to EFTRs. Every time I go, I try to avoid these HPB talks. I'm a consultant with luminal gastroenterologist. I think they are running out of spaces to put Axios now. But I think with bigger powers bring bigger responsibilities. Are we auditing the harm which these procedures are causing to our patients? Are we learning from our mistakes? Does our trainees, does our advanced endoscopist, are they feeling empowered enough to report them? Have we got a structure in place to learn from them? And if we learn from them, are we implementing that learning? Is it translating to change in practice on an individual basis or on the institution basis or in some instances on the country basis? Clinical audits. So I think we all aspire to be researchers, bring some new technologies, develop some new skills, help developing a new drug. But I think I'm hoping all of you will agree with me that a lot of the things which we do can be improved by applying the knowledge which we already have, applying it consistently and applying it safely. And that's where the role of the clinical audit is equally important. Yes, research will generate new knowledge, but a knowledge which is not applied, a knowledge which is not applied in a safe way, a knowledge which is not ilm baghair amal, I don't think that is going to be of any help for us as consultant or for our patients. So I think there are like a lot of audits which are endoscopy related. As my role in endoscopy lead, I'm looking into it, starting from the individual endoscopist to looking in the unit as a whole. But I think audits are equally important as it comes to the patient safety and improving our practice as research. And then education and training. So again, as individuals, as a gastroenterology department, as a Manchester Foundation Trust, and then NHS, we have to prove that we are all learning, unlearning, and relearning, which is the definition of knowledge in the 21st century, isn't it? I think 5 years ago, we only had 4 or 5 drugs in IBD. I think Dr. Tawseef has just left, but I think he will agree with me that there is like a flood of drugs coming our way. And I'm sure this is the same is true about endoscopy as well. So we all have to, maybe in a few years' time, forget about what we have learned, learn something new, and then apply it to our practice. And I think that is something which we have to be proving on a continuous basis. So I think the way it is done is the conference like today, our CME points, the regular appraisals which are done for trainees, but also for every consultant every year. And then every 5 year, a revalidation process which gets submitted to the General Medical Council. And patient, I think that everything which we are doing through, I went to medical school in 2003, that's when I started. I got my CCT in 2020. So it's been 17 years of training, and I think then we go through everything else, fellowships, attending conferences, coming up with new techniques. But are we remembering what is all for? It is all for the patients. They are the heroes of the show. The show is for them. And I think as an organization, as an individual, as a gastroenterology department, I have to prove that it is for them, that they are satisfied with the service. It could be something as personal as getting a consent for a procedure, or it could just be the way my endoscopy department is designed. It could be just changing the temperature of the waiting area. But in the end of the day, the endoscopy department is to deliver the service for the patient. Yes, my comfort is important. Yes, my health is important. But in the end of the day, we should not forget that we all exist, that this whole service exists for the betterment, for the service of the patient. We are privileged enough. People trust us with information they will not share with their partners, with their parents, with their kids. But we are trusted with that information. And that's why we have got the responsibility to share that for the right reason and to be proving that. And then staff management. So again, I think we all know that the world is changing. We need to get the right people, and then we need to support them. We all go through different and difficult phases in our life, and we will have individuals who might not be performing at the level which they are. Have we got a mechanism in place to identify it? If we identify it, have we got a mechanism in place to help them out of it? And I think this is again an ongoing process. I think this graph, Professor Kamani did touch on it briefly in one of our slides. And I'll be honest, this is an AI generated chart. And I will not claim that I've counted the zeros or I can count them. But I think it does say, I think it gives you a taste of where we stand. And I think when you look at the blue dot there, you will expect we should not have a health system in place at all. But I think it's testament to the hard work you guys have been doing for years. The wonderful mentors which we have, who have been providing and still bringing all these cutting edge technologies here. And I think that just brings me to today's session of the training, that our biggest asset is our workforce. We have got dedicated people who have dedicated their life for establishing the services, running the services. And I think our training program is the opportunity to make the most of it, to make it better. And I think that give us the best chance that we can make up for some of the resource difference which we have in terms of money or equipment. So just a few slides left, which will be about the training program in gastroenterology in United Kingdom. So JRCPTB, which is the Joint Royal College Training Board, it is responsible for designing the curriculum for gastroenterology training. And it has been revised a couple of years ago, and usually the capabilities expected of gastroenterology consultant, the curriculum divides it into 3 headings. So one will be the generic capabilities, then there will be the clinical capabilities, and then specialty capabilities. But this diagram, which again is taken from that similar paper about the curriculum, I think the thing which I like about it the most is the professional values and behavior lies at the heart of it. And I think values is what we need to do to enshrine it in our trainees. Because if we have the right values in place, then we can get the professional skill and the professional knowledge. But without the right values, I think the professional skill and the professional knowledge, in my opinion, is unlikely to be of benefit to the patient which they are serving. So with the governance hat on, and to show that how some of these governance components are part of the curriculum in gastroenterology. So part of the generic capabilities are divided again to 4 subheadings. So it will be your professional behavior and trust, communication, team working and leadership, safety and quality, and wider professional practice. And I think if you keep all those 7 pillars in mind, you can already start placing some of those under some of these subheadings. And you can see that how from day one in the training, the expectation is there that endoscopy skills are important, endoscopy numbers are important, the number of gastroenterology patients you are seeing in the clinic is important. But without these generic skills, we're not going to get a good, complete doctor. And those are the skills which has to be equally instilled in the trainees, and the trainees have to show that they are achieving it along with all those other numbers which we expect from our trainees. And just to be even more specific with some of those, so if I take just one of the headings, and I will not go through all of them, so please don't be worried, I'm not going to take long from here. But if I go with the professional behavior and trust, so subheading will be that the trainee who's going to become a consultant should be able to function successfully within the organizational structure of the NHS. And the way they are going to do that is, along with their clinical skills, prove that they've got leadership skills, they know what the general medical council professional requirements are, they are open and transparent, they are learning and they are teaching, and they are showing engagement in their career planning. And some of the practical evidence, I think I know some of the question in some of you's mind will be, how do they prove that? How can someone prove all of these generic general things? So one tool which we use is the MCR is a multiple consultant report. So every year a trainee is supposed to get 4 multiple consultant report, which is from 4 consultants. And during the training, when there is a 5 year of gastroenterology training, you are supposed to be in 5 different hospitals. So you're not going to spend more than a year in one hospital. So you can imagine just in those 5 years, if you don't do any out of program fellowship, there will be at least 20 consultants writing a report on your practice. And they're not just going to comment on the clinical and endoscopic skill, but showing that how a trainee is showing some of these responsibilities. And then the governance structure, which we have talked about, I think they will be showing an audit annually, presenting in the morbidity and mortality meetings, and then presenting usually for some of the other these safety forums. If you look into safety and quality, I think they will show that they have to show that safety is their priority. They shouldn't show non-technical skills at the same time as their technical skills. They should be able to share good practice as well, be it the right forum, be local, national, or international. And they should be able to recognize their own limit and their personal competence. So I think the idea that the clinical governance, I think, is something which helps us to achieve the best quality of care for our patient and maintain it. But I think with the curriculum, you can see that it starts with the trainees learning some of these skills and then contributing it to the governance system, and then carrying it on as consultant in their practice. So I hope in these quick 20 minutes I've been able to convince, or at least start putting the idea that governance does ensure safety, effectiveness, and quality care. It does help with continuous improvement through audits, education, and management. It ensures patient involvement. And I think gastroenterology training is a good opportunity to introduce and strengthen the clinical governance structures. I will finish with Rumi. Again, sometimes the task does appear difficult or sometimes it does look different. So the great Rumi did say, Aqal goyat shash jihada dast, beberuni rah neest. You are bounded by the time and space and you can't escape it. But again, the great Rumi has the answer. Rah hast warafta amban baraha. So where there is passion, the way not only exists, but the heart has been on it many times. Thank you.
Thank you, Dr. Rizwan, for such an insightful talk, and you have highlighted quite important aspects of training. Now, I would like to proceed for question and answer sessions. Questions can be from the speakers and expert panel. So, is
Yeah.
there any question from the audience?
Acha, I think we have many members of faculty of gastroenterology, College of Physicians and Surgeons, Pakistan, including dean and worthy members. So the faculty is working in different fronts at CPSP because not only this is the problem that we are facing induction of the new trainees in the GI fellowship program, and there are several reasons that we have not been able to induct GI fellows for the last I think 6 or 7 terms. That no, not I am not aware that any of the program has inducted anyone in the GI fellowship program because of the easy options that are available after the intermediate module that our candidates have. Second front that faculty is facing is the advanced training in gastroenterology. What are the challenges and what are the opportunities? And these are the major problems that we have to negotiate with College of Physician and Surgeon Pakistan, and we have been putting different solutions. So I would ask Yasun Nabi, he's the dean, current dean, that what are the problems that we are facing, why these problems arose, and what are the solutions a way forward. And Nadeem mentioned some of the solutions, and some of these similar solutions we put forward to College of Physicians and Surgeons. So, yes, what do you say about that?
So, thank you very much. Dr. Zagam has opened two actual avenues, or two important points. First is what is what is Faculty of Gastroenterology doing to improve the gastroenterology training for the young medical graduates? So, in addition to a better teaching and training program in the FCP's gastroenterology, at the same time we are trying to start 3 advanced programs. One is in the advanced gastroenterology endoscopy. Number 2 is hepatology, and thirdly, neogastroenterology. So these are 3 programs which Faculty of Gastroenterology plans to start. The documents have been prepared; they're ready to be submitted. And to be honest, we have been submitting them to the Executive Council of CPSP for the past 2 or 3 years, and every time it has been returned to us because of certain change of policies at the last moment, or in the recent past, or because of other technical lacunas. But I guess currently we are almost there to submit it once more. So that is on one side, that those who are in the field of gastroenterology and practicing gastroenterology, for them there's an opportunity that they can have better training. But you see, when we talk of better training, we must remember and we must understand that if you want to have further training, you have to work like a trainee. It's not that you are going to act like a consultant and you want to be trained. In order to get the training, you have to work, act, and behave like a trainee. And that's the only way. Whatever you know, you have to relearn, and you have to relearn for all the new procedures, all the procedures that you think that you have learned, and all the procedures which are available in that department to be learned. Now, coming back to the most sore point that we have been discussing and that we have been trying to tackle for the past now almost 5 years, let me appraise you that starting from 2012 onwards, there have been repeated meetings and feedback from the supervisors and examiners of FCPS gastroenterology given to the Executive Council of the College of Physician Surgeons on the account that the training of the people who are appearing in the FCPS gastroenterology is not adequate. Their clinical acumen is not at par. Their uh, clinical proficiency seems to be deficient, although they have been passing. Now, there used to be a time where the passing percentage used to be around 15-20%. And at one point in a city very near to us, there was an actual just get the up this halla gulla that the young people who did not pass, they actually created a scene and they broke the windows and the doors of a local center. Why? Because they thought that they've been failed intentionally, and at number of centers, exactly similar kind of impression was that. But that is one aspect of the human behavior. I'm not touching on that. That was just to highlight that the feeling was such. But on the other hand, the examiners and the supervisors were continuously giving feedback that the training uh, proficiency is not up to the mark, the acumen is not up to the mark, the candidates are not up to the mark. So after number of these feedbacks, uh, the executive council, along with the its figurehead president, they asked us that okay, if this is the scenario, what exactly do you want? So at that time, not just us, rather the feeling was there in other specialties as well. For example, in the in the people who were doing cardiology, these were the two front runners, cardiology and gastroenterology. They were the two main super specialties. At that time, uh, for both of the specialties, the offer was given that, okay, we want to make you second specialty. At that time, um the one of the option was to take all the subspecialties to second fellowship. Maybe an exception was made for certain reason at that time, but in the meeting where we opted as a faculty that we should be given a status of second fellowship, cardiology people backed out at the last moment. Now we understand that CPSP should have taken a policy decision instead of taking a decision based on the will of one faculty and not the will of the other faculty. We understand that that should have been a um, uh, policy decision to be taken by CPSP, but that is something which is again another avenue. Now, for the past 3 to 4 years, we have been continuously trying to look into the subject once again, thinking that how to improve the training and teaching system. We've been talking about maybe we should increase the medicine training component and then uh, taking them for the gastroenterology training for another 4 years. So, meaning by a total of 7 years of program. Then there was another option that, okay, 4 years of FCPS medicine without any examination, FCPS medicine eligible, and then continuing with the FCPS gastroenterology training. That was number two option. Number three option was that uh, changing the intermediate module to uh, number three and then continuing with the program. Uh, that was just, but you see, the issue is not that simple. These are policy decisions. CPSP alone cannot take that decision. CPSP has to consult the public health department, the main stakeholders. Somebody has to pay for them. Somebody has to pay for the stipends. Somebody has to pay for the training slots. Uh, Year five stipend is obviously different from year one stipend. Are the public health departments ready to listen to the CPSP? We as a faculty, we want to engage Executive Council of CPSP, and the Executive Council of CPSP gives us the feedback. Okay, uh, what do you think that in the past 4 or 5 years, the centers which have been training previously, and you all have been mentioning that their training has not been at par, have they improved substantially in the past 4 or 5 years? Have they changed their equipment? Have they changed their faculty? Have they changed their training routines? How can you claim that okay, if we switch back to the previous system of 2 years of internal medicine followed by 3 4 years of gastroenterology, the training levels of the candidates is going to improve substantially? In one of the presentations, I was watching the slide that 85% of people are practicing advanced gastroenterology in various parts of the country. Now, who are they? Where are they? What exactly do they mean by advanced gastroenterology? And what's the definition of advanced gastroenterology? We are struggling on the people who have done FCPS gastroenterology, CPSP, that the training level of the candidates is not up to the mark. So what were they doing at that time? Were they concentrating enough on the training of that people, of those candidates? And those the candidates of that time, they are the young consultants of this time. Now, looking at the performance, although there's no hard and fast yardstick on the basis of which we can evaluate their performance, uh, why are the people going to UK or to America or to other places for the training? When I announced that okay, you can come to an X center, people aren't ready to pledge their time. You see, to become a trainee, you have to be available 100% of the time. During their training time, if they're doing an evening job at another place for financial reasons, in the morning time they're trying to get the training, again in fatigued and compromised fashion. Lots of these things are there. So coming back to the point, I shall just stop here so that the other people may give their input. But that was the big overview. As a faculty, we are trying to rectify the things. We have suggested a number of options to the Executive Council of CPSB. I understand that in next 6 months or so, we should be getting a change of policy or change of this particular status, which is definitely affecting the training status in the gastroenterology. But at the same time, I shall urge, and at the same, I shall point out that have we brought any change in our system that we expect that with a new change, we'll be able to train our candidates better, and the previous feedbacks that we have been receiving from the trainees, from the examiners and supervisors, that's not going to come back. So thank you very much.
Thanks, Gas. Quick questions. I was told that there are 310 trainees who've completed to get trained. And what he has told is exactly what I hear. And that's almost 90% who come to attend our hands-on colonoscopy course. If we don't have structured programs like the US or UK, where in US, they have at least 6 years for general gastroenterology, 3 years of internal medicine, and then you go for 3 years GI, where there is a structured program in UK, correct me if I'm wrong, about 10 years, 5 in medicine and approximately four in medicine and 5 in GI or thereabouts. I mean, are we really serious that we will be able to provide with the unstructured training that we have in our country in most centers and then expect that these guys are going to be, let's be honest, most of the people want many trainees because they are workhorse. They are the ones that run your unit. And is that why we want trainees? And that's the question all the trainers have to ask. While the trainees have to ask, why are they willing to go to United States and UK spend 2 years on research jobs, and then eventually get into an internal medicine training program, spend 3 years, and then go 3 years, and then spend another year or two for advanced endoscopy. They don't have a problem doing it there. But they want everything done here in 5 years. I'm sorry, it's totally unthinkable. And I leave this for you. MD programs have been started. You will get lots of candidates. I spoke to one of the MD candidate and I asked, why are you doing this? I get to be a consultant in 5 years. Shortcut, sir. If that's why you want to do GI, then the way GI is moving with the holes that we are seeing, I wish all the best to the next generation. I'm sure I won't be there. But you guys, the young ones, have to think about it.
Sir, just to give a comment, the gastroenterology is not only the endoscopy. We are insisting on endoscopy, a good colonoscopy, a good ERCP advanced endoscopy. Gastroenterology also includes the clinical care of the patients. So the issue is, I was one of them who supported this to go for the second fellowship level 4. But I realized that, as Dr. Ghyas mentioned, the other subspecialties, they backed out, and we were left with this only one specialty. As Dr. Nadeem said, the other subspecialties are not coming with this as a level 4 program. So we are facing problems. I am working in a government hospital. I had at one time 26 trainees working under our different supervisors. Now, right now, there is no FCPS trainee in my department, the gastroenterology department of Sheikh Zayed Hospital, one of the oldest one. So, as Dr. Nadeem has mentioned, that I'm relying on SHOs who are behaving like telephone operators, telling us the thing. Right now, I'm facing a case in the Healthcare Commission that my patient's endoscopy being not done, even the trainee was there, but the consultant did not do the endoscopy. So, sir, the program is badly affected with this decision. In private sector, you can have 2 or 3 trainees, you can do this. The government sector, where the things are free, people are coming. A patient care is definitely affected by this, our decision. And I will ask Dr. Ghyas, what is the way forward now? Sir, you said that the policy making, I agree, we have tried our level best, but CPSP said that they have a program or they will not change in 2 or 3. So what is the way forward? Because now, right now, 3 MD students are working with me, all are females. Dr. Nazish there, that we are supporting female gastroenterologists, but the thing is, what is the way forward? We all know this is where there's a discussion.
Sir, I have one comment.
Is not gender biased.
Yes.
But Dr. Kamran.
Sir, I have being member of the faculty of gastroenterology of College of Physicians and Surgeons. We have been learning while attending the meetings with the senior faculty like you people. The question is, Professor Asad Saab said that people in England or America, they spend more time to become consultant gastroenterologist. I think to become skillful gastroenterologist, you need to spend time in a quality place. It's not the duration. What I understand is it's not 6 or 10 years. It's a quality place where you are trained in a structured program. Like now, we have made it mandatory to be a fellow of College of Physicians in internal medicine, and then you can join the gastroenterology. But the question is, the trainees, 1 or 2 or 3 who are coming to gastroenterology program, are we now in a better position to train them in the best way, or it's the same? To me, like, there is no difference for that person who has joined a gastroenterology training program right now, who is a fellow of medicine, because the structure is the same. We are taking the same duties from them. We are sending them to the ERs. We are not giving them second fellowship. There must be a difference between a second fellowship and a residency program. Like, we are dealing them as residents. We are not dealing them as second fellowship. We need to change our perspective. This is what is required. It's not that we increase the time. And we must devise some mechanism, being the responsible people for the college, to devise certain mechanism, and we convince the executive body of the college to implement that. That's the way forward, I think.
Excuse me. Look, we are confusing two things. One, that for day-to-day patient care, there are SHOs, there are MOs, whatever you may call them, okay? And then there are trainees. When you are a trainee, you need to have that night calls, you need to go to the ER, because that part of the management is as important as doing an endoscopy. So there shouldn't be anything. Probably I was one of the proponent of the second fellowship, and that's everybody knows in this room probably. The reason is only simple. Pakistan is the only country in the world which is offering a subspecialty without having a medical diploma. Period. Are we different, or the rest of the people stupid? Now, how many years you take? There are countries which will have only, even just across the border, India is there. Even there are countries where we'll have a medicine diploma and then they will have apprenticeship. And whenever their supervisor will think, just like UK would do in the past, that this person is ready, even it may be 2 years, it may be 3 years or 4 years. Ask the person visiting from Japan what they are doing. Are they less competent than us? Now the other thing is that we are missing one thing. Now somebody said I had 26 or 40 trainees. How can you marshal them? How can you should have an attendance in the morning rather. I visited one of the units and I just asked how many beds you have. They said 16 to be honest. And they had 20, 26 or something like that trainees. How can you concentrate on their trainings? How can a one-to-one or supervised training can be there? So we are, look, somebody is going to the gastroenterology MD, best of luck. If you ask me, please produce these gastroenterologists, but ask one question. I'm really, I would say that at times I feel, I would say I'm scared. The reason is, will I allow someone trained at some particular center to do a colonoscopy on me? And I can assure you, the person who I trained, there are a few sitting here. I would say they can do my colonoscopy, my child colonoscopy, or whatever procedure, because they know that how their training was unsupervised training, how strict we were. So it is an unsupervised. If you want a force, workhorse force to run your wards, okay, forget. So you need to, one more thing, sir, I will request the faculty, rather as a member of the faculty, we should re-accredit, just like the way we started, but we should re-accredit our centers. How they are doing it? You should ask the trainees as well. And the trainees are told that if you say that we are lacking in this thing, then okay, our center will be recognized, where will you go? So we are mixing things up. Either doing it now, how it was converted to, how it was, we need to go back to around 20 years ago, how it was converted to this 5 years, because someone thought that they will get fellows or trainees after medicine. It started as medicine initially, and then after a year or so, their trainee would left. But there were centers in Karachi, they were producing, nobody left them. So there was a problem somewhere in the selection criteria or the training or whatever. So we, at that time, majority decided, and it was said, okay, we will take after 2 years of this internal medicine. So we were from the era where internal medicine was 3 years. Now it has become a 4 years, and now they are not going back to those 3 years, the internal medicine, and they are saying we proceed. Now even then, when medicine was 3 years, AKU had a residency program of 4 years and a surgical residency program of 5 years, because they thought that 3 years is not good enough to produce a general surgeon. And after that, they would have advanced fellowship in either in trauma or oncology or breast or whatever. So we are confusing things up here. So please, it's not like that you are getting, ask the government to provide you medical officers. Previously, there used to be medical officers running these wards. Ask the government. If the government is not interested, why you are interested? Why the CPs? Who said that they are not interested? No. Who said?
کیونکہ it's such an interesting thing. Hold it. It's such an interesting topic. Such an interesting topic, and everybody is interested. So one last question, and then because of the interest of time, we'll have to cap it.
Okay, so Professor Dr.
Dr.
Sharbat Khan is waiting for a long time. I'm sorry.
سر بڑی صبر سے میں نے باتیں سنی ہیں. اب میں امید کرتی ہوں کہ ہماری باتیں بھی سب لوگ صبر سے سنیں گے. نہیں, میں اپنے دل کی باتیں بولوں گی. سر میں نے جو ہے میں آئی ایم ایم کا پروڈکٹ ہوں. آواز آ رہی ہے میری؟ اچھا, میں آئی ایم ایم کا پروڈکٹ ہوں. میں نے 2005 میں گریجویٹ کیا ہے اور میں نے 2013 کے اندر ایف سی پی ایس گیسٹرونٹالوجی کیا. 2015 میں سپروائزر بن گئی گیسٹرونٹالوجی کی, اور الحمدللہ میرے بھی 16 کینڈیڈیٹس کنسلٹنٹ ہیں اور ورکنگ ان پاکستان اینڈ ابراڈ ایز ویل, اور اس سال کے آخر تک 20 کا جو فگر ہے کراس ہو جائے گا. تو جو اگر آپ کہتے ہیں نا کہ اسٹوڈنٹس جو ہیں بڑے نالائق آ گئے ہیں گیسٹرو کے اندر, تو صرف گیسٹرو میں نالائق کیوں آ رہے ہیں؟ کارڈیولوجی نیفرولوجی میں نالائق نہیں گئے؟ اور کون سے سپروائزر ہیں جو کمپلین کر رہے ہیں؟ ان کی ٹریننگز میں ڈیفیشنسی ہوگی. ہم سے تو کبھی کسی نے نہیں پوچھا آ کر کہ آپ کے کینڈیڈیٹس کیسے ہیں. وہ جو بار بار کمپلین کر رہے ہیں ان کی ایویلویشن ہونی چاہیے تھی. اور جہاں تک پالیسیز کی بات ہے کہ پالیسیز بن گئیں تو اب کیا ہوگا, تو اس ملک میں تو آئین چینج ہو جاتا ہے. پالیسیز کیا چیز ہیں, کیا چیز ہیں پالیسیز؟ اور جو سوڈو گیسٹرونٹالوجسٹ کی بات ہوئی ہے, تو ہم نے بڑی محنت کر کر کے ایسے وارڈ ایسے ہاسپٹلس میں جہاں پہ گیسٹرونٹالوجی کا کوئی کانسیپٹ نہیں تھا اور سب انٹرنل میڈیسن والوں نے ٹیک اوور کیا تھا, بہت ایفرٹس کر کے ہم نے اپنے گیسٹرونٹالوجی کے وارڈز بنائے, اپنے یونٹس بنائے. اس ڈیسیجن کے بعد سے ہمارے جو یونٹس ہیں وہ تھوڑے عرصے میں وینشڈ ہو جائیں گے. پوری کوشش کی جا رہی ہے کہ انہیں وینش کیا جائے, کیونکہ ہر انٹرنل میڈیسن جو ہے وہ یہ کولونوسکوپی کے ورک شاپ اٹینڈ کرتا ہے. یہ والا ورک شاپ, وہ ایک ورک شاپ ایک ہفتے کا اٹینڈ کیا اور اس کے بعد وہ کہتا ہے مجھے آتی ہے, اور وہ ایک ٹیکنیشین کے ساتھ کھڑا ہوتا ہے اور وہ انڈوسکوپی کر لیتا ہے. تو ہمارا تو پورا پروگرام سی پی ایس پی نے ڈسٹروائے کر دیا. ہم پچھلے 3 سالوں سے اس طرح کا ایک پروگرام ارینج کرتے ہیں اور اس پہ سب ڈسکشن کرتے ہیں, اور اس کا اینڈ میں کوئی رزلٹ نہیں نکلتا. اور سب ہم نے بھی اب ایم ڈی پروگرام اسٹارٹ کر دیا ہے, اور پنجاب میں ہر جگہ پہ ہو گیا ہے. تو سر یہی ہوگا, جو اسٹوڈنٹس ویری کرتے ہیں اور سپروائزر نے بھی محنت کرنی ہے, صرف وہ کمپلین نہیں کرے کہ یہ اچھے نہیں ہیں, نالائق ہیں.
Let me respond to this particular thing. MD is now level 4 program. It is again from after MD medicine is going to be MD gastroenterology. So that's number one. So that اچھا وہ دوبارہ ٹھیک اوکے, تو وہی جو ایلیجیبل والی بات ہو گئی. سو یہ تھوڑا سا چینج آ گئی. دوسری بات یہ آ گئی کہ سی پی ایس پی از آلریڈی آن ٹو دس تھنگ کہ انہوں نے جو سینٹرز ہیں ان کی ری ایکریڈیٹیشن کا پروسیس اسٹارٹ کیا ہوا ہے. سو دیٹ تھنگ ول بی ٹیکن کیئر آف. نمبر 3 جو آن جاب ٹریننگ ہے کینڈیڈیٹس کی, اور اس کا سسٹم جو ہے اس کو امپروو کرنے کی کوشش کی گئی ہے. اس میں پچھلے 2 سال سے ڈاپ سمنی سیکس انٹروڈیوس کیا. پہلے پائلٹ ایل جی ایچ میں ہوا, ڈاکٹر زیگم نے اپنے سینٹر میں کیا, تو اٹ از بین رولڈ آؤٹ ناؤ. وہ ٹھیک ہے کہ انڈرسٹینڈ کہ اس وقت آپ یہ کہہ سکتے ہیں کہ جی ہمارے پاس کینڈیڈیٹس ہی نہیں تو اس پہ ہم کدھر اپلائی کریں. بٹ اسٹل if you look at the figure 201 candidate ابھی بھی ہے which have yet to appear in the exam. تو آپ کے جو چیزیں ہیں بالکل ٹھیک ہے. we understand, we acknowledge that, and as a faculty and from on behalf of college physician surgeon, یہ نہیں کہ ہم نے آپ کے پروگرام کو تباہ کر دیے, and we don't want to destroy anybody's program. جب بھی کوئی آپ ایک کرو ہوتا ہے تو اس کے سائڈوں پہ ہمیشہ ایکسیپشنز ہوتی ہیں. 5%, 5%, 2.5%, 2.5%, 95% پیرابولک کرو کے اندر ہی آتے ہیں. اب انفارچونیٹلی وہ پیرابولک کرو جو میس ہے وہ اس کا امپیکٹ آیا ہے, اور جو ایکسیپشنل پروگرامز ہیں وہ بھی ہٹ ہو گئے ہیں, یا ادروائز اٹس جسٹ اے ٹرانزیشن دیٹ وی آر گوئنگ تھرو. میں آپ سے پہلے یہ کی کہ in next 6 months to 9 months time we should be expecting a change which is going to bring the FCPS gastroenterology back on its track.
Excuse me.
یہ ڈسکشن چلتی جائے گی تو اس میں اگر کیونکہ ان the interest of time I think we need to کامران صاحب جیسے کہیں.
سر ایک صرف یہ وارڈ کی ورک فورس ہی نہیں ہے, ہماری آؤٹ ڈورز بھی تباہ ہو رہی ہیں. ہمارے آؤٹ ڈورز میں ایچ اوز بیٹھے ہوئے ہیں, میڈیکل آفیسرز بیٹھے ہوئے ہیں.
میرا خیال ہے لاسٹ کمنٹ جو ہے فرام ڈاکٹر صادق, دین وی ول کنکلوڈ دیٹ مے بی ڈاکٹر فاروقی شربت بھی ویٹنگ.
نہیں ادھر ہم جو ہے ویٹ کر رہے ہیں, آپ لوگ جو ہے
سوری ڈاکٹر شربت خان از ویٹنگ فار لانگ.
جی شربت آپ
بات
بتا
یہ ہے کہ پریکٹیکل کیا ہے نا, ان پریکٹیکل نا what's the time one PG or one resident is taking to qualify gastroenterology? 4 years medicine, then he will take 1 or 2 years for exam. You should calculate that time also, and the majority takes more than this time. Then only medicine he qualifies in 5 to 6 years. Then he will come to gastroenterology, and 3 years that comes 9 years. And then he will go for the exam. In the exam he will take 1 to 3 years, then 11 years. And you are planning for advanced endoscopy program, FCPS in advanced endoscopy 2 years. Then he will go for the exam 1 to 2 years. When I calculated this period, he will take minimum of 15 years. Then after 15 years, what will he do? For the PGs, for the training of the PGs, and for his own home. تو یہ 15 سال جو ہے آپ کیلکولیٹ کر, یہ آپ ایک سینٹر پہ تو سر اپلائی نہ کریں. اب بات میری بات سنیں نا, اب ایک پی کے ایل آئی ہے یا شفا انٹرنیشنل, یہ تو آپ پریفری کے یعنی لاڑکانہ کوئٹہ کے ہاسپٹلس پہ آپ جو ہے اپلائی نہیں کر سکتے ہیں. وہاں پہ جو ہے ضرورت ہے لیکن لوگ نہیں ہیں. اب لاسٹ 3 ایئرس سے گیسٹرونٹرالوجی میں ایک پی جی بھی نہیں آیا. ایک پی جی آیا تھا, وہ اس نے ایف سی پی ایس میڈیسن کیا ہوا تھا, 2 دن کے بعد ہی رین اوے.
Sharbar, your points are well taken, and I think Sadiq and Faruqi آپ بتا دیں پھر ساری, then we'll conclude that.
I think this session needs another conference. We need to conclude.
Last 2 comments and we'll
Okay,
conclude.
sir.
جی فاروقی.
تھینک یو ویری مچ. میرا خیال میں کہ فرسٹ آف آل کنگریٹس کامران کی بہت اچھا سیشن رہا, جہاں پہ ندیم صاحب کا بہت اچھا اسٹڈی ہم نے جو ہے نا اس کو دیکھا. اس کے بعد ونڈرفل. میں ان فیکٹ جسٹ آن لائٹ نوٹ 1994 میں میں نے میڈیسن ایف سی پی ایس کیا, پھر کنسلٹنٹ بنا, پھر موڈ ہوا کہ گیسٹو کر لیں. میرے 3 ایگزامینر غیاض بھائی, زیغم بھائی, وسنین صاحب وہ چلے گئے. ایسا تھا جب میں وہاں پہ 1 سال میں 3 ایگزام ہو رہے ہوتے تھے. پہلے ایگزام میں آئی واز اے 1 کینڈیڈیٹ, 6 ایگزامینر تھے. اس کے بعد پھر فیل ہو گیا. دوسرا اگین 1 کینڈیڈیٹ 6 ایگزامینر, پھر 1 کینڈیڈیٹ 6 ایگزامینر. ان ایک کینڈیڈیٹ پاکستان سے آتا تھا, ایگزامینر لاہور سے, اسلام آباد سے اور جگہ سے آتے تھے. تھنگ واز دیٹ, اینڈ آئی ایم ناٹ سیئنگ کہ ہونا نہیں چاہیے. الحمدللہ the first FCPS medicine in pulmonology was Najmul Hassan, then was Khalid Hamid, and then was me in Pakistan. Then man mein Sadiq Memon was FCPS gastro chala gaya. After 21 years وہی چیزیں پھر اسی طرف ہم جا رہے ہیں کہ کینڈیڈیٹس نہیں ہیں, وہ نہیں ہے. لیکن well point, I have been in faculty of medicine as well as in gastro as well. ایاز بھائی نے بڑا صحیح بولا کہ we need, سعد بھائی نے بولا کہ we need to have a holistic approach. ہمارے ٹریننگ میں بھی مسئلہ ہے, ہمارے پالیسیز میں بھی مسئلہ ہے. اٹس اے گڈ نیوز کہ سی پی ایس پی سوچ رہی ہے کہ ہم شاید اس کو ریوزٹ کریں, لیکن गोइंग बैक टू दैट, जहाँ से शुरू किया था, जो मैंने अपनी एग्जांपल दी, और शायद अभी वही हो रहा है कि एग्जाम में एग्जामिनर ज़्यादा होंगे, कैंडिडेट्स कम होंगे. आई थिंक वी नीड अ फुल होलिस्टिक अप्रोच, मल्टी प्रोंग पॉलिसी. पेशेंट केयर भी चाहिए, वर्कलोड भी है, ट्रेनिंग क्या होनी चाहिए, ये तमाम चीज़ों को देखना होगा, और इसको इंडिविजुअल लेवल से जाके एज ए पॉलिसी करना होगा. ये मेरी बात है.
Thank you, Faruqi. Short comment from Sadiq. Yeah. Then I'll like to hear from Dr. Amna as well, because day before yesterday we were in the Zoom meeting with College of Physicians and Surgeons Pakistan, and Amna would briefly comment on that. But पहले Sadiq आप बता दें.
सर मैं ये कह रहा हूँ कि जैसे डॉक्टर साली ने कहा, अगर इसको आप 10 साल भी कर दो, इसकी क्या गारंटी है कि वो क्वालिटी होगा. तो क्वालिटी इस पे ड्यूरेशन पे मेरे ख्याल से नहीं कंसिडर करनी चाहिए. उस सेंटर की, उस प्रोग्राम की, उसको स्ट्रेंथन करना चाहिए. मतलब ये एक चीज़ जो हमें है कि वो हो रही, क्योंकि मैं इससे भी एग्री कर रहा हूँ. क्वालिटी इस तरह है, मैं नाम नहीं लेना चाहता हूँ, ऐसे गैस्ट्रोएंट्रोलॉजी FCPS हैं जो कि इंटूबेशन नहीं कर सकते हैं EGD की, एंड दे आर एग्ज़ाम पास. तो हैज़ ए फैकल्टी हमें ये भी सोचना चाहिए कि उसकी जो ये वाली स्किल्स हैं वो किस तरह असेस करें. उसके लिए कल रह गई है. और गैस्ट्रो इसलिए वो डिसएडवांटेज पे है कि हमें ये फाइट करनी चाहिए, या तो 4 years ऑल सब स्पेशलिटी हो, ताकि एक रेस शुरू हो जाए. चाहे वो गैस्ट्रो इस वक्त डिसएडवांटेजेस में नहीं है कि ये 4 year है, आप उसको 4 year करें, लेकिन इक्वल अपॉर्चुनिटी हो, ताकि वो रास्ते बंद हो शॉर्टकट्स के.
जी, what is the way forward, Amna? What are the solutions? How to come out of this crisis?
For last many years, I'm the part of the same lot. हम सब एक ही जगह पे हैं और एक ही कश्ती के सवार हैं. Thinking and thinking and thinking. What are the root causes? What were the problems? Who has taken the decision? Why they have taken the decision? अच्छा जी, रिवर्ट करते हैं तो फिर क्या होगा? Okay, the reason was like quality, and then how the quality will be improved, and all. Multiple options I've been thinking, the committee members were thinking and thinking and thinking. There is no doubt about, we once again has approached the residency committee of CPSP, and we have requested Dr. Arif Zaman for a meeting, and again we have talked to them, and they again like send back the same thing to us. What was the scenario so many years ago? There were so many responses, so many supervisors, so many examiners. The passing rate was so low, and then the trainees has broken the windows of a center because they were not passed. So all of that scenario brought team of people of that time to think that okay, karna kya hai? Now the question is, ठीक है, दोबारा option number 1, 2, 3, 4, what we can do as a CPSP faculty, एक group है, वो कर क्या सकता है सिवाय सोचने के. So सोच के whatever the options are, 1, 2, 3, 4, we've discussed. Now they've asked us again कि okay, जो भी आपके proposals हैं वो लिख के हमें भेजें, हम एक दफ़ा दोबारा लिख के भेजेंगे, फिर देखें hierarchy क्या decide करती है. But I think I have a question for everyone. Who's closest to the trainee? Who's closest to the trainee? डेली आप उससे मिलते हैं, डेली आप उसको देखते हैं, डेली आप उससे सलाम दुआ करते हैं, डेली आप देखते हैं ये बच्चा काम कैसा कर रहा है. Supervises. You change it to the first or second if the programs and the supervisor will not pay an attention towards the trainees training, things will not improve. It's not the kahani of one center, it's the kahani of whole country. If one center is doing well, there is not necessarily that कि जी 50 दूसरे सेंटर भी उतना ही अच्छा काम करें. Don't we know that कि गवर्नमेंट हॉस्पिटल के अंदर शाम को लोग जॉब्स करते हैं और फिर सुबह में इंटर्न्स ज़्यादातर पेशेंट्स देख रहे होते हैं, and the PGs has limited. I've done work in the government center. I've been intern house officer in a government center. My PGs were used to going to a job in a nearby hospital, एक OPD में जाके jobs कर रहे होते. The question is, देखें, whatever the CPSP faculty could do, they're doing it again. Dr. Zagham ne khair ye share kar diya. It's too early to share again. We've knocked the door once again. But the question comes back again to the supervisors and training programs. The program directors and the supervisors are actually clearly responsible to improve the training in their own center. CPSP is a central body, वो रोज़ाना आके आपको नहीं देख सकती कि आप कैसे ट्रेन कर रहे हैं. تو آئی تھنک ٹریننگ کا ڈیوریشن بڑھانے سے مسئلہ نہیں حل ہوگا, ٹریننگ کی کوالٹی ایٹ ایچ اینڈ ایوری سینٹر کو بہتر کرنے سے مسئلہ بہتر ہوگا. اینڈ آئی تھنک وین گوئنگ وی آل فرام ہیئر, کچھ بھی مسئلے کا حل نکلے, the best solution is every single supervisor and a program director in every hospital, please go back, reflect and improve in and out of your training program, and better assessment, better delivery of the curriculum, better assessment of their competencies. jahan kahin kami hai usko pura karein. That will be the best way of improving the quality of the program, whatever would it be, first, سیکنڈ اینڈ آل. صرف سیکنڈ پہ بھی کنورٹ کرنے سے مسئلہ حل نہیں ہوگا جب تک کوالٹی آف دا پروگرام نہیں بہتر ہوگی. وائی دا پیپل آر گوئنگ ٹو یو کے؟ بیٹر اکاؤنٹیبلٹی, better training system, supervisors are giving time to the trainees. The same thing is actually goes in the US.
Thank you, Amna.
Thank you
very much. I think we should conclude now. Thank you very much.
Thank you so much. I'll conclude, and I would like to ask the speakers and chairs for a group photo, please. Thank you.